Hello and welcome. In this video, we are going to do the question answer session on the RCOG guideline on endometrial hyperplasia, which was published in 2016. We go to the first question. When we read our guidelines, what do we mean by grade A recommendation or a rating of 1++ in a recommendation? The time starts now. The answer is that grade A recommendation means the evidence has been gathered through a randomized controlled study. Scientifically, this is the best way to get results which are not biased or confounded by the investigator or the patient. Any result which is obtained by this method is given the rating of 1++. Now we come to the second question. From where did we get the current classification of endometrial hyperplasia? Your time starts now. In 2014, the World Health Organization recommended a change to the old classification. This separated endometrial hyperplasia into two groups, which was based upon the presence of cytological atypia. So you either had a diagnosis of hyperplasia without atypia or atypical hyperplasia. That means hyperplasia with atypia. We come to the third question. What are the risk factors for endometrial hyperplasia? Your 10 seconds starts now. Obesity and inactivity are two of the major risk factors associated with the development of endometrial cancer and endometrial hyperplasia. Other modifiable risk factors include dietary habits, exercise, and the use of hormonal therapy. The majority of these factors fit well with unopposed estrogen theory. What is the diagnostic and surveillance methods recommended for endometrial hyperplasia? Your 15 seconds starts now. If the patient is high risk, or if on routine ultrasound scanning, a thickened endometrium is discovered, then endometrial sampling is the best way to diagnose or to exclude endometrial hyperplasia. If outpatient sampling is not possible or no tissue is obtained, then take a tissue sample by doing a diagnostic hysteroscopy and endometrial biopsy. Transvaginal ultrasound can be used for diagnosis in special centers which have specialized in this technique, and they have trained ultrasonographers as well as very high quality machines. However, CT and MRI or biomarkers cannot be used for diagnosis. How will you counsel women who have diagnosis of endometrial hyperplasia without atypia? Your 15 seconds starts now. Women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over a 20-year period. The majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. Reversible risk factors such as obesity and the use of hormone replacement therapy should be identified and addressed if possible. How will you manage women who have diagnosis of endometrial hyperplasia without atypia? Considering the risk of conversion to endometrial cancer, such women are placed on continuous oral and local intrauterine levonorgestrel releasing uterine system for progestogen release. This is effective in achieving regression of endometrial hyperplasia when there is no atypia, and the highest level of evidence is available for this recommendation by the Green Top Journal. What medication will you give to a woman with hyperplasia without atypia and in what dose? Your 15 seconds starts now. Your Green Top guideline by the Royal College recommends continuous progestogens should be used, which should be either medroxyprogesterone 10 to 20 milligrams per day or norethistérone 10 to 15 milligrams per day for women who decline the intrauterine system for release of levonorgestrel. Cyclical progestogens, which means giving for 21 days and withdrawing for 7 days, should not be used because they are less effective in inducing regression of endometrial hyperplasia without atypia in comparison with continuous oral progestogens or the LNG-IUS system. And the level of evidence for this is level A. For how long should you keep patients on medical treatment? Your 15 seconds starts now. Treatment with oral progestogens or the LNG intrauterine system should be for a minimum of 6 months in order to induce histological regression of endometrial hyperplasia without atypia. If the adverse effects are tolerable and fertility is not desired, women should be encouraged to retain the levonorgestrel intrauterine system for up to 5 years, as this reduces the risk of relapse, especially if it alleviates abnormal uterine symptoms. How should you follow up patients on medical treatment? Your time for the answer starts now. So the answer also applies to those patients who have endometrial hyperplasia without atypia. In these patients, once they have been put on oral medication, or even if they are not on oral medication, then you should do an endometrial biopsy every 3 to 6 months. If 2 consecutive biopsies are negative. That means that the endometrium is normal and there is no evidence of hyperplasia with or without atypia, then that means now they can shift to a yearly or an annual endometrial biopsy surveillance or follow-up. Patients should be advised that if during this time period, if they have any irregularity of vaginal bleeding, then they should see the doctor immediately. What is the indication of surgical management for patients with endometrial hyperplasia without atypia? Your answer time starts now. Hysterectomy should not be considered as a first-line treatment for hyperplasia without atypia because progestogen therapy induces histological and symptomatic remission in the majority of women, and by not doing surgery, you will avoid the morbidity which is associated with major surgery. Hysterectomy will be indicated in women who don't want fertility, or if there is progression to atypical hyperplasia on repeat biopsy, or if the patient has been taking oral medication and having endometrial biopsies and the endometrial hyperplasia is not regressing despite 12 months of treatment, or if the patient has got a persistent atypical abnormal vaginal bleeding, or if the patient does not want to have repeat biopsies. In such situations, then a hysterectomy is indicated. So in other words, we can categorize these patients into 2 or 3 groups, and these are women who want to have surgery, who don't want fertility, and who don't want to have repeat biopsies. And the other group is that if there is a progression to atypical hyperplasia on repeat biopsy, or if there is irregularity of vaginal bleeding. What kind of surgical treatment can be offered to women with endometrial hyperplasia without atypia? The answer time starts now. The answer is a total abdominal hysterectomy, preferably with bilateral salpingo-oophorectomy, should be offered, and a laparoscopic approach is preferred. Endometrial ablation is not recommended for the treatment of endometrial hyperplasia because complete and persistent endometrial destruction cannot be ensured. An intrauterine adhesion formation may preclude future endometrial histological surveillance. How will you manage a woman with atypical endometrial hyperplasia? Now we are talking of hyperplasia with atypia. If she does not want to have surgery or is unsuitable for surgery. Your answer time starts now. And the answer is, if women wish to retain their fertility despite the endometrium having atypical cells, then they must be seriously counseled about the risk of underlying malignancy and subsequently progression to endometrial cancer. Pre-treatment investigations should aim to rule out invasive endometrial cancer or coexisting ovarian cancer. Histology, imaging, and tumor marker results should be reviewed in a multidisciplinary meeting, and a plan for management and ongoing endometrial surveillance should be formulated. Next question. How will you follow up a woman with atypical hyperplasia who has not had a hysterectomy? Routine endometrial surveillance should include endometrial biopsy. Review intervals should be every 3 months until 2 consecutive negative biopsies are obtained. In women who are asymptomatic, that is, there is no vaginal bleeding, no symptoms whatsoever, and there is evidence of histological regression, then you can, and there are 2 negative biopsies, then long-term follow-up can be done with endometrial biopsy every 6 to 12 months until a hysterectomy is performed. How should endometrial hyperplasia be managed in women who are wishing to conceive? Your 15 seconds starts now. Despite regression of disease should be achieved on at least one endometrial sample before women can be allowed to attempt to conceive. Women with endometrial hyperplasia who wish to conceive should be referred to a fertility specialist to discuss the options for attempting conception, further assessment, and appropriate treatment. Assisted reproduction may be considered as the live birth rate is higher and it may prevent relapse compared with women who attempt natural conception. Prior to assisted reproduction, regression of endometrial hyperplasia should be achieved, as this is associated with higher implantation and clinical pregnancy rates. Can you give hormone replacement therapy to a patient with endometrial hyperplasia? Your answer's time starts now. So systemic estrogen-only hormone replacement therapy should not be used in women with a uterus. All women taking HRT should be encouraged to report any unscheduled vaginal bleeding promptly. Women with endometrial hyperplasia taking a sequential hormone replacement therapy preparation who wish to continue hormone replacement therapy should be advised to change to continuous progestogen intake using the levonorgestrel intrauterine system or a continuous combined HRT preparation orally. Consequent or subsequent management should be described in the preceding sections of the guideline. How will you manage a patient with breast cancer and endometrial hyperplasia who is on tamoxifen? Your answer time starts now. Women taking tamoxifen should be informed about the increased risk of developing endometrial hyperplasia and cancer. They should be encouraged to report any abnormal vaginal bleeding or discharge promptly. Is there any way you can reduce the risk for endometrial hyperplasia or cancer while on tamoxifen? Your answer time starts now. There is evidence that the levonorgestrel intrauterine system prevents polyp formation and it reduces the incidence of endometrial hyperplasia in women on tamoxifen. The effect of this medication on breast cancer is not known and is uncertain. In case hyperplasia develops, the need for tamoxifen should be reassessed and management should be according to the histological classification of endometrial hyperplasia and in conjunction with a woman's oncologist. With this, we come to the end of our video. Thank you for watching. If you like the video, then please press the like button, subscribe, comment, share, and press the bell icon for information about subsequent videos. Thank you and goodbye.